Wait till he comes back in. Everyone have a good lunch? No? Well, good to see you all after lunch. I'm Kim. I'm on the board with APNC, and I've got the pleasure to introduce today's speaker, Ms. Wanda Berger. Wanda is a former nurse, has been working in the field since 2003. Her specialties include trauma, co-occurring, PTSD, military, and civilian. She is also an approved continuing education provider for the MBCC and for NADAC. So without further ado, here's Wanda. She's going to make it nice and engaging for you after lunch.
Hello, and when she says engaging, what I mean by that is there's another live microphone. We don't have a lot of people in the room, but we do a live microphone here. There's a bunch of people that signed online. We're gonna start by, and I asked these guys if they had their running shoes on. And if you want to be on the camera, we like you to come up here between these two black lines. And if not, they'll take the camera back there and with the microphone. So first off, let's just see by the show of hands here, and they can show hands on the computer as well. How many of you work with PTSD? How many? Great, great. Almost everybody in the room. Online, are you seeing some hands online? Okay, all right. Now, what about how many of you work with first responders? We got some first responders back here. So we're down in Wilmington, pretty close to Fayetteville. How many of you all are from the Wilmington, Fayetteville area? Camp Lejeune? Camp Lejeune? Okay. So when I came down Sunday night, we're from the Piedmont area now. One of my co-trainers who works for Camp Lejeune in the clinical department and is one of the clinical directors there, Mary Mack. Are any of you familiar with Mary? Somebody's hiding down there? No? So I met with her and said, you know, this is my training I have for the week. For our training coming up, is there anything else I should know, anything new? And so I picked her brain a little bit on Sunday night. So there'll be a few little tidbits that I will be adding that's actually not on the training. But one of the reasons we're having this as interactive is because you folks who are out there in the trenches, and I'm up in the Piedmont area, but we're going to learn from the statistics about how many folks that are in the military that live in North Carolina. It's a large part of the population. And so right now, and normally I bring little prizes and forgot to do so, but right now, before we get to the rest of the slides, what percentage of military do you believe resides in North Carolina? Guess. Anybody want to guess? What, 10%? Anybody else? 40%. Anybody else? 30% and 60%. We're going to find out. All right. And I'm going to tell you, it is between the 30 and 60%. That's a pretty high percentage down here. All right. And as an aside, I was falling asleep coming down and was jerked awake when My husband slammed on the brakes and the car beside us went through the red light and almost smashed the oncoming vehicle. And he said, "We've hit Fayetteville." Lots of testosterone in Fayetteville. And one of the little sides. Okay, so before we head on, what do you think are a couple of the biggest differences when you work with a military population versus a civilian population? I'm just trying to pick your brains before we move ahead to see what you guys know, what your fund of knowledge is. Okay, there you go.
And
We're going to have you start over so they can get it on the recording.
okay, there's an organization that Give an Hour. Have you heard of it?
No,
Give
I
Hour.
haven't.
It's all right. It's yeah. That's
So it's
cool.
called Give an Hour. Okay,
Yes.
great. Okay. And
And-
it works with veterans?
Yes.
Okay.
Yes. And I've been privileged to work with several veterans and sometimes we meet in an office, sometimes we meet in a library, sometimes we meet different places because I'm currently I don't have an office as of COVID. I just with my individual therapy business was going downhill. So it doesn't matter. I found these people to be tremendously traumatized. The ones I was working with, deeply traumatized. And on top of that, they want to hide it. So there's a little difference. People who are actively in the military, they don't want a military therapist. They don't want to go to the Veterans Administration. They don't want anybody to know. So our organization protects the privacy, but I mean, it's stunning how affected they are. Almost just functioning.
I want you guys to hold on to that. I saw somebody sort of shaking their head, maybe having a different opinion. I'd like to hear from that. What
Yeah.
we have heard, what we've heard out in outpatient private practice, people who are not taking insurances or who can take private pay and not take insurances, we've heard exactly that. Yeah, but I'm saying that we have, and there's some of the things I posted on Facebook, I posted in WUVA, or there's private groups in Facebook of therapists who are actually helping to take care of military and that. Okay, sir, you in the shirt and in the glasses, were you agreeing with her or disagreeing? Have you a different?
Hi, I work for the Durham VA, and no, I just made a quick comment to my friend here who also works with soldiers. Your one comment about active duty doesn't want to go to the VA. They actually are not eligible for VA services until they separate from the military. That was my
Okay.
only comment.
Thank you for that input. Ma'am in the back.
Well, one of the things I have found is with my active duty clients is they are very concerned about how their notes are written because they are turned in often to their commands.
Yes.
So my active duty clients are often less forthcoming with what they have to report than my ones that are already out. And I also do a lot of just veterans, retired military is where the ones that were medically retired.
Okay, one of the tidbits that Mary gave to me on Sunday night was about the notes. And she said that the active people know that, number one, their commanding officers do know if they're going for help. Number two, they know what's written in their notes. They sign a waiver. And so they're worried about that. And number 3, there's something about their firearms, depending on the diagnostic code and if they're even allowed to work. So those were 3 points that she brought up that I had not actually placed in the slides I normally talk about, but she wanted us to make sure that we brought them up. Yes, ma'am.
There are military and family life counselors that are on Camp Lejeune and every installation. And we don't keep notes. One of the attractions of our program is that we do not keep notes. We don't send any records. We don't discuss whatever our active duty members are talking to us about. We are bound by certain confidentiality agreements not to share any of that. So that's one of the attractions,
Yes.
that we don't keep any records.
Yes, and that's where we're going to go with some of this, ma'am.
My curiosity, I'm sorry. I'm curious though, do their superior officers know they're coming to you? They do, yes.
Influx, and
What do
they can say they have an appointment, but they do not have to say what the appointment is about.
Okay,
Okay.
okay. I was curious about that because I've never heard that. And I do work with retired, so you're right also that some of them, you're right.
Okay, so,
Okay.
folks, this is why we have an interactive program. Because while I have knowledge and have researched and have even gone to one of the clinical directors from Camp Lejeune to pick their brain, other folks have other programs, and we're gathering all the information we can to give you a wealth of information from this hour-and-a-half training today. Plus, you won't fall asleep, right? Interactive? Okay. I am particularly asked for a cold room, so, all right. Oh, I also am offering on November 20th, 3 CEUs. They're for both MBCC and NADAC. And we also get the North Carolina Substance Abuse Program CEUs. You will need to send me your email so that the week of the training, I can send you an invitation to the Zoom. If you try to connect to the Zoom without my invitation, you will not be able to connect. The Zoom training is live. It is interactive. It is from 10 o'clock to 1 o'clock. And if you're duly certified or duly licensed, you will get 3 CEUs for both of those. But the email you send to is stillwaterstraining1@gmail.com. The subject of the training is I am totally forgetting it and try to pull it up and cannot pull up the internet here. I will let you know before the end of the day. They told me by the time I get back to the hotel, I will have that up for you. But if you go on my website, stillwaterstraining.net, it will have the training on November 20th. Okay, but it will be free for you. I just need to have your email so I can invite you. All right. It's one way that I have to give back to the program. All right. Does trauma always lead to PTSD? People have trauma? No. It does not always lead to PTSD. So what are some reasons that it doesn't always lead to PTSD? Ever heard the word resilience? Supports? Those of us in the addiction field, resilience, supports. If the folks have those things, right, they can bounce back. How many times have we seen someone go through something we're thinking, wow, they should have been able to make it, but they had nothing. They had nobody. and they just spiraled down. And someone else has had 5 or 10 different things before they finally succumb to the trauma and addiction. But no, it doesn't always trauma doesn't always lead to PTSD. And every bad experience doesn't always equal trauma, does it? Someone's been in a very bad car accident and they can bounce back and say, you know what, I'm alive and I'm going to live. Somebody else has a bad car accident and next thing they're on disability. They don't have a job. They lose their wife, their kids, right? We've seen it. We live this every day with people, right? So many negative things will happen to people that do not lead to trauma. And traumas don't always lead to PTSD. Traumas may need to lead to PTSD, but people can recover. People can and they do recover. Hey, if people didn't recover, would we be doing what we do? I don't think I would. I don't think I'd beat my head against the wall. Would you? All right. So in order to get PTSD, you got to have a traumatizing event. And then I draw like a pie for my clients when I diagnose them with PTSD, because I have gone into the specialty of doing PTSD and dual diagnoses. Caseloads packed, and mostly packed with PTSD, and half my clients are first responders. I've got NSA, FBI, CIA, detectives, firemen, and I draw a circle and I'll say one piece of it is anxiety or anger, right? It's implosion or explosion. And you know what, you guys, I'm not going to lose you right now. There's 3 more pieces. What are the other 3 pieces of PTSD? What would the other 3 pieces of the pie be? How about hypervigilance, avoidance, and depression? Can you see that? Now, our military folks are going to share that pie with civilians. We're going to have avoidance. We're going to have some hypervigilance. We're going to have anxiousness or anger. And we're going to have some depression. Now, in PTSD, as with all other diagnoses, that depression can be anywhere from like a dysthymia, a little bit sad, to like major depression, right? What do you know about your military guys that are going to get depressed? What have you seen? Have you seen deep depression in them? One of the reasons some of them say, if I tell you, I think I've got PTSD, are they going to take my guns? Because what's happened with some of them? Yeah. There's been some suicides. Yeah. What do we know about men and suicide? Men, violent means with men, because when the men are going to do it, it's going to be final, right? And the men are going to follow through. And the military, you know, they've been taught, if you're going to do something, do it. So they're going to be more final, correct? Again, even though they're male and they have PTSD like a civilian, they're going to, and men follow through more than women. your military guy, if he's going to try it, he's going to, in all likelihood, in all probability, follow through quicker than your average mill. Any disagreement on that from anyone? Okay, so hyperarousal. Have you seen this in your folks in PTSD? Have you seen this interfere in their lives? How do you think that the hyperarousal interferes differently with the military, and not just military men, but military women? How do you think it interferes differently with their families than with civilians? Let's talk about that for a minute. Do you know? Have you seen it? What do you think? So I'm going to wait for some feedback from you folks that work with it. I know the lady in the red works with this, lady right here. We've got a couple people.
What I have seen is that hyperarousal shows up with active duty in their work, and at home, they're quick to anger, short-tempered, and don't always, they get in trouble with their leadership for being oppositional. So that's what I've noticed.
Thank you. That's exactly right. Anybody else? Have you seen that?
Well, I had a client who was back from Afghanistan, and basically his job was to have hyper arousal to stay alive in Afghanistan. But he did bring that back with him. And I think that's very hard, because it's hard to focus on something else and do something well. And when you're in the military, they're very, not the word demanding. It's not loose. It's very tight ship.
Yeah.
So it's you have to be careful and not show it.
Yeah. So I like that tight ship. You've got to be careful and not show it. So what happens, it is a two-edged sword for the military folks, because they're in hyper arousal with their and I don't want to say the wrong word here, because the different branches, they call their teams different. The different branches are different words, so I'm not going to say the wrong word here, but whatever team they're on, they call them, it's a different branch. It's their family, okay? And if they were to have a family, they would have been issued a family. But then if they're living with their family on base, then if they're going home, what is their biological family seeing and dealing with, right? So we've got some major relationship issues going on. And so then we've got displaced aggression. We got to deal with that as well. And then these guys are really feeling guilt. Do you get that? And are you dealing with the guys that are retired?
From the military.
Okay,
We don't
so-
see active duty. We see
So what about
veterans.
So what about the vets who are retired? Have they been able to segue back into civilian life, or are they carrying?
A lot of the guys, especially those, a percentage of those, especially those that have seen combat, really struggle with that.
And that's what we see. That's what we see a lot. Some of us in the outpatient practices, that they come to us, they want to pay cash because they don't want to even go to the Veterans Association, because they don't
Right.
want it on their record, even since
Yeah,
they've
and-
retired.
And there is another service that is not affiliated with the VA that was created for that by veterans for that specific purpose. Veterans who don't trust the VA because it's still the federal government.
Yeah,
There are the vet centers, which again, they're not affiliated with VA. We have no access to those records. And the vet centers are in the community, like in strip shopping centers. They're not in big hospitals and clinics. And they are only for combat veterans. They do therapy. They do not do medication management at the vet centers.
okay, and I've actually have a couple of those folks over from, it's Kernersville and near High Point, that they still don't trust them. They don't believe that they don't have the records. So they're coming over to Yakinville from there, driving over. So anyhow, they're still not believing. Thank you for your interaction. The rest of you, you're learning a little bit more than what's on the slides. Okay. All right. Now, re-experiencing. Wow. A lot of folks with PTSD, especially, rape, incest, major accidents, fires, a lot of re-experiencing. What about combat? Lot of re-experiencing. I did a talk for the VA in Charlotte, and the VA and another program that worked specifically with veterans. And the one gentleman, they had to get him another apartment to live in because when he looked out of his apartment window, he thought that the trees were Japanese out in the yard. Could you imagine? Yeah, we really re-experiencing and hyper arousal, especially with the veterans. It's more, do you get it? It's more intense, much more intense for them. And it's much more intense for the families. Are you working with the families as well? Okay. All right. So we're all aware of what some of the signs of the PTSD. We go to 3:30, right? Okay. So I want to make sure we're pacing this good. I want to make sure we're getting information from everyone, but I want to make sure we get through the slides too. Okay. Here are some of the most common signs of PTSD. Feeling upset with reminders. I just gave you an example of a reminder for one of the veterans. He saw trees that reminded him of Japanese. Having nightmares. I have a guy that was a Army Ranger. He's 6'5", and he parachuted in, and he helped get 33 body bags and laid them out on the cargo ship. He can't sleep now. He's 50 some years old. He can't sleep. He's still seeing those body bags. He'll have nightmares and vivid memories to this day of that. I have a NSA agent that's from several counties away, and he still tells me of flying into a country like Russia. I don't know if it was Russia, and I'm having to, he was taking equipment in and having to get it into a safe place and having to run and hide, these stories. And this guy's 70, different types of trauma and still having memories of years ago. All right. The wife of this NSA guy is CIA. And you know what she says? I want to shake him because he's not emotional. Where's his emotions? What do we do with that, guys? And I don't mean disrespect when I say guys, that's part of, my dad was a master sergeant and took me up North Pittsburgh and raised me up there. So guys is one of those Pittsburghese things. So what do we do? What do we do with people, our guys who get emotionally shut off from their families? Because they are, aren't they? Most of them. Do you have a trick? Anybody have a trick? We apply some of our skills that we have. Our trauma interventions, do they work for you? Okay. Again, most of our people, we get some women who have been molested and that they'll come in and say, you know, my husband or my fiance, you know, says I'm emotionally cut off. You know, we can work with them. And a lot of times we can do some trauma interventions and get them built back up. Many times with the guys who've been in combat, it's a lot of work to get them to where the wife finally says, well, we're making some progress. All right. Feeling numb and losing interest in things they once cared about. I have a family right now that the guy, he was, you know, the cycle of pre-deployment, deployment, and then, you know, coming back in and that whole cycle. He went out and then he was supposed to be in for a while, but they kicked him back out like really quick. And then the wife said he was this very loving, touchy-feely type of guy, very romantic. And after he came back from the second cycle, he wasn't that way anymore. She didn't recognize him. They're coming for couples therapy. And he said, you know, his best friend was shot. And he just emotionally, he's not over it yet. And he's afraid to get close to anyone again. Feeling numb, afraid to have those feelings out there. That constantly on guard, that's the hypervigilance. Having angry outbursts. I use this couple again as an example. He's little things irritate him. Are you thinking of any of your clients right now that you've seen some things? I see a bunch of heads nodding, yes. Having trouble concentrating. Do you know that has, I have a fireman who had a real bad experience with the fire, they almost lost a child, and he's coming with his 3 teenagers, and he's having trouble concentrating and following through with things with his teenagers after this horrible fire and what happened with the child that they were rescuing. And even in session, he's having trouble focusing in session. This happens with the trauma. So we work on our interventions with folks. All right. Being jumpy or easily startled. Again, that's the hypervigilance, hyper startle reflect. Surviving should never be easier than being home. So it says PTSD chances after trauma. So I put this in here because we said at the get-go, not every bad thing leads to trauma, and not every trauma leads to PTSD. So what are the things that eventually lead people to trauma? So people who suffer from PTSD will relive the thing that happened to them. They don't have enough resilience or support to get through it. They're going to have the nightmares. They're going to have the flashbacks. They're going to have difficulty sleeping. They're going to feel detached or estranged. I met someone at the conference the first day, and later I think she even shared in one of the groups, her work is working with folks with dissociative disorder, okay? And because her trauma led to dissociative disorder, okay? So it depends on how bad the trauma was and how bad the person it affected, how good the resilience and how good the supports are. So going back to the military versus the civilian, if the military family doesn't understand how to support the military person, where's their supports? Do you feel it's important to work with the family? So right now I'm going to ask you guys, what supports do you have or know of for the families of your military folks? Yes.
I will say with our organization, we get a lot of spouses or friends, loved ones that are really just wanting to know what is PTSD. Does my loved one have it? And like really providing that psychoeducation is super helpful so they know that it's not personal. And then we also have a resource bank specifically for family members that are looking for that support, especially when it is involved with PTSD or domestic violence involved.
Great. That's good.
There are also resources on base for active duty and their families, family advocacy groups, spouses groups, all sorts of programs that are designed to support the families and increase their resilience. So there's a lot of resources right on base.
Fantastic. That's great. That's great. You ladies in the back that work with the military, do you have some specific resources for the families?
Well, we work primarily with the actual active duty client. We periodically do, if they request like family counseling together, but we also will refer to other programs in the area or to family advocacy on the base, depending on if they want it. So some of the ones that we deal with do not often want the on-base services because of what their MOS may be, for example. So it depends, but whatever they ask for, we try to definitely link them within Jacksonville. But we primarily work with the military person themselves.
That's great. Do you all, go ahead. Do you all see a need for the family to be involved?
I definitely do. One resource I just thought of that we use a lot is a Camaraderie Foundation. If they're a post 9/11 veteran though, they only do post 9/11. So I will say veterans, especially Vietnam veterans that call in, it is really hard to find specific resources for them because a lot of the resources nowadays are geared towards more post 9/11. But we do use Camaraderie Foundation a lot for couples counseling. I mean, they do PTSD treatment. They do a lot of different programs there.
And I'm going to mention this right now so that I don't forget it at the end. Those of you who do have some resources, when they call for the feedback at the end, if you would post your resources that the others might be able to use, that would be great. You would be reaching out to help some other folks, okay? When I was in the pilot program of the trauma-focused cognitive behavioral program here in North Carolina, UNC and Duke did it. And they said to steal shamelessly and share relentlessly. So what they meant was you find some resources and you take them and you share them. And so one thing that I did with this little contest they had I had a bunch of resources and I shared a bunch of resources because, hey, they might help some people, right? So might as well do that. No, no sense keeping all the stuff to ourselves, right? I do something with my PTSD folks. I draw, and they'd asked me if I wanted some extra tools, and I thought I wanted to keep this simple, wanted to keep this interacting. But do you know when they draw the little girl, the little stick figure, they draw the triangle with the circle on top of the head and the stick legs and the stick arms. I draw that girl and I'll put a box in her hand and I put an E in the box. I put a T on the circle. I put a heart in the triangle and I put an R on the leg. And I say, an event is something that happens to us, either good or bad. And when the event happens, we have an automatic thought. And with that automatic thought, we have an automatic feeling. And with that automatic feeling, we have an automatic reaction, okay? That's the cognitive behavioral triangle that we learned in trauma-focused work. And what I tell my people, all my kids and all my adults, is we're going to change the reaction into an action. So therapy, the goal is for them to take control. Hey, you're coming to therapy to take control over your reactions and to make it an action, right? The only thing you can break in that triangle is your action. You're not going to be breaking the event that happens. You can't, you initially cannot break that thought or that emotion, but you can start to change that reaction. You can start to change that by doing some deep breathing, by walking away, by singing, doing something, right? Doing that old DBT measure of putting a little band on your wrist and touch. I always say touch it, don't snap it, because if you have an old cutter or something, you don't want them beating themselves up, but touching it and say, just stop it. And to say something positive instead of negative. And we turn that reaction into an action. Folks, I've been doing that with the PTSD since I learned the trauma-focused work. I think they started it in 2006 and I got certified in it in 2007. We change the reaction into an action. Been doing this for kids age 3 up to 19, and I have skewed this for adults, and it works. I've seen great changes, and I've used this for my military guys as well. And they are changing their negative thoughts into positive thoughts, and they're changing their reactions into actions. If you don't take anything away from today, take 2 things away. Take away, change your reactions into actions, positive thoughts, negative thoughts into positive thoughts. All right, those are 2 things that you can learn from today, as well as some resources from the other folks, okay? All right, your mindset matters, folks. What do we get when we get someone who has had a traumatic event? We get a couple kinds of people that come in with the PTSD, don't we? They've had a traumatic event, and we get somebody that comes in and says, I want to make this better. And we get someone that comes in and they just want to complain. How many have had this, somebody who wants to get better? Let me see. How many have had the complainers? We get both, right? So, you know how you find out who wants to get it better? You know who you find out who wants to change is when you give them some homework and they come back and they've done it, right? Folks, those of you who have military guys, guess what? They're used to following orders. right? They're going to therapy. They're asking for instruction, right? Am I right? Yeah. My military guys do my homework and they get better. They do. I'm telling you, this triangle works. Changing the reaction into an action, it works. And I'm going to tell you, they walk through therapy like that. It's an in and out door. It really is. It works. Okay. So our military guys are worse at pulling away from the family than our regular folks are. Have you seen that? Do you agree? That's another reason why resources are really good for the family. They're really needed. It's almost best to have a support group for the families of the military folks. Correct? Yeah. All right. Now, do your folks admit to the emotional symptoms of the PTSD? Because they want to act aggressive and not stressed. That's the one difference between military and civilians, is they're going to come off and they're going to act more aggressive than stressed. They may be depressed and have headaches and worries and are nervous and have fears and are unhappy. But until they really trust you, they're not going to tell you, because they want to come off as being the tough guy, right? Aren't they groomed to be tough? They're trained to be tough. Now I'm going to tell you, my 6'4", 6'5", and he's a black guy too. He's big. He has told me he is not sleeping. He is sad. He won't admit to being depressed, but he says he's not happy. And he's got a lot of headaches and stomach aches. He's telling me it took him a while. And he had been going to the VA, but he is also involved in one of the programs that I oversee. And he came to me and he said, I've been watching you. You're not fully yourself, and I need someone to talk to. Sure. Took him a couple months before he broke down and told me everything he needed to. And he's made a lot of progress. But they got to trust you. But you got to build up that rapport. And he has finally told his wife all the stuff. But we got to build that trust. The reason I've picked this training to do is somehow, probably in my old age, and because all of my relatives, from my grandparents and uncles, my father, my kids, nephews, everybody in the world but my husband that's related to me decided to go into the military. So being raised by all those people, everywhere from World War II to the Korean War to the Vietnam War to the, oh Lord, Afghan and the OEF and the OIF and all of that. We have, and all the boys went into a different branch. So learned how to talk to them. But anyhow, it's important. And I've seen some depression and I've seen nightmares on some of them, and it's not good. And so they need us. And it's important for us to know the difference. Very important. We got some common themes of PTSD. You're going to see more of the anger in the military folks. And the affect in PTSD is sometimes hard to manage. You got your folks with PTSD. Sometimes you don't know which one's going to walk in the door, do you? They're going to be happy, going to be sad, right? You're going to be anxious, don't know. Are they going to blame themselves? They're going to blame somebody else today. Are they hopeless today? Not trusting anybody. Relationships having some trouble. Work failure, shame and guilt. And again, in the military, those guys can really rack up the shame and guilt. They can really put it on themselves. Whether they share that with you or not, once you get to know them. All right. Okay, so the population with PTSD. Here is in the whole US, 3.5% in the general population, 1.8 of males and 5.2 of females. Now, when they do this, these are the ones that have admitted to it. And you know, when people do the statistics and they take, fill out their forms, a lot of people do not tell the truth. So we believe that this is low. Look at the veterans, look at the general population, and look at the Vietnam vets. What do you see is difference there, percentage-wise? 5 times as much, 5 times as high, folks. I took that particular poll back then because of the percentage difference. That's why I put that year up there. Now, population studies in RAND in 2008, Gulf War is 10%. Now the OEF is the Operation Enduring Freedom that was in Afghanistan, and the Operation Iraqi Freedom, those are 13.8%. So the conclusion is that while PTSD is not unusual, it's not suffered by the majority of those who were in the war. Again, why do you think that is? Why do you think that there are a lot of people in the war, but only not even a quarter? Yes, Sarah?
Because they're not reporting it.
Part of it's they're not reporting it. We those of us who do some of this stuff, we think it's really closer to a third. We really think it's 30-some to 40% is what we're guessing. We can't prove that. Anybody else, would you guess that for what you've seen, what's coming to you? Okay, there's fallout from PTSD. Health issues. The one gentleman, all of them have some major health issues. Every one of them has some major health issues. And some of them have lost some of their jobs. And a couple of them are in recovery. Those of you who have some veterans or those who are active, do they have a substance use disorder? Yes, I see some heads nodded, yes. Yeah, how about major depression, anxiety? Yep, bunch of heads rattling there. And a higher risk of lower quality of life. Relationship issues. And again, when the title of this is civilian versus military, yes, everybody with PTSD has some issues, normally have some issues with relationships. but we see a higher issue with relationships with the military. Anybody disagree with that? Any disagreements? Okay. And, oh, violence. Folks, do you know that, I talked about Fayetteville with the aggressive driving. Do you know that the rate of violence and domestic violence in Fayetteville and around the military bases is very high? Are you guys aware of that? What do you think that is? It's a little sidestep, but also a sidestep with PTSD for family, right? Just to be aware of. Another area, yeah. Testosterone and a subset of PTSD from some of the anxiety and the stress of the job, right? Okay. There are some military mental health models of PTSD. So, community mental health based on the unexpected. And there's freezing and shutting down. Have any of your guys froze and shut down on you? The person is the victim. And we have the military acquired PTSD. People adapt and survive. Military guys, they are aggressive, they're not stressed. And this comes from Adler and Castro. Any of you ever read any of Adler and Castro's works? They have done stuff starting in 2003. Last works of theirs I reviewed was 218. They do a lot of military stuff. If you haven't perused any of their stuff, check it out. And you can get some good used books online. Books that are 25, 35 bucks, you can pick up sometimes for $5, $6 online, and really neat to build up your library on this type of work. Okay, so here's some of our bases, all right? Camp Geiger. Guys, I don't know where Camp Geiger is. I didn't write this down. Yes, where is it? Jacksonville. Okay. Camp Lejeune. Cherry Point. One of our sons was at Cherry Point. My dad was at Camp Lejeune. Fort Bragg. One of my officers was at Fort Bragg. New River Air Station. Seymour Johnson. There are more than 750,000 in North Carolina. North Carolina deployed more than 5,886 troops since 9/11. There are 150,000 active duty in North Carolina. And the military population of North Carolina as of 3 years ago comprised 35%. 35% is military in North Carolina. All right. So, if 35% of the population is military, that means that a lot of their families also military. So half of North Carolina is military or related to military, right? How important are we to the military? That should make us really important, folks. Agreed? So therapists are important to everyone, but if there's that much military here, we really are. Okay, here's our deployment cycle. Pre-deployment. Where do most folks hang out? What do they do when they're in pre-deployment? What do you know about the cycle? Who knows about the cycle? Anybody know the cycle? Have you worked with folks in the cycle? What do you know about the cycle back in the back?
When they're in pre-deployment, a lot of times they're out in the field. And I've got a client currently that's in there for 6 weeks, and some of them go to Caxton, California, some are at Camp Lejeune on base. It depends on where they're working up to go.
All right. And then deployment. How long folks are they in deployment?
Depends on where they go, up to 9 months to a year.
All right. And then sustainment.
What do you mean by sustainment?
Sustainment means they could be, I think it's when they come, no, post-deployments when they come back. Sustainment might be they what? On station, yeah.
Okay.
And then post-deployments when they come back, and then reintegrations when they go back into the regular community. And then redeployment as they're going to get ready to go back. When I told you about the young man who he had just gotten married and he had the pre-deployment, and then he was supposed to come back for the reintegration, but he didn't come back for the reintegration. They kicked him right back into the pre-deployment. And so he didn't get that cycle back with his wife. And it really, they did end up separating. It was just too new in their relationship. And this loving, kind guy became very aggressive. He was not who she had married. Okay, so this slide is similar to the last slide. This is more actually what it does to the military folks. So they will freeze and shut down. They do see themselves as a victim, although they will not tell people that they're the victim. They will adapt. They will not, they think that they're adapting. They're actually being maladaptive, but in their minds, they're adapting. Their families will see them as very maladaptive, and that's why it's very important for the families to be brought into the therapy and to be part of their recovery with the PTSD. So you see PTSD therapy as a recovery time, recovering from PTSD, because as I said earlier, when there's a traumatic event and you can have resiliency and you can have the support, you can grow through this and recover. You don't have to have that diagnosis forever. You can come through that. Community mental health, sometimes they don't understand. Do you believe that every therapist out there don't understand? I posted some groups on WOVA. One of the groups was Triad Mental Health from the Winston area. Before I came down here, I think it was Friday or Saturday, someone posted on there and said, does anyone have room for private pay? I have a client, his military, who doesn't want to go to the VA. He probably has PTSD. Doesn't want to run a risk of losing his guns. That's my paraphrase version of what the sentence said. All these young therapists jumped on there. Well, he needs to have a therapist to diagnose him. And if he has PTSD, he's going to have to give his guns up. I mean, you should have heard the things. And I got on here and I said, please send him to someone with a background in PTSD and military who will not be sending any reports to anyone without his permission. And any of you who really want to learn something, there are some trainings going on at APNC that you may be able to log on and see virtually. Nobody replied to my comment. And nobody replied anymore to the string. But in there, there were several people, well, he has to see so-and-so, and he's going to have to give his guns up. And I'm like, cringing, just cringing at the answers. There are people in our field, and these were mental health folks. These were not anybody that knew anything about addictions and certainly nothing about trauma. None of them were trauma experts and none of them were addictions. And most of them weren't even licensed professional counselors. They were social workers. So we have to be careful with consulting and who we work with and, and what we do, and the information, that we have, and the experience. Yes, ma'am.
People don't come to you to be judged
Yeah.
and to be told what to do. We just had a class where basically it made it very clear that our job is to do what the client wants. If his goal is to stay in the military, then I work with that. I don't judge him and decide for him whether his children can stay with him or he can have his gun. But after saying that, it takes a long time with these clients. Long time. It's not like a 6-week, or a 6-session therapy. And often, I think you have to really be on their side. That's what I think. And these
Yeah.
people weren't, that's all.
Yeah, we do. And we have to be very careful for the trust and to not be judging the folks. Okay. The big thing in the military is the stigma with mental health counseling. They don't want the labels. And I have been speaking with a couple folks who are working on the new DSM, and they are looking at adding PTSS. Have any of you heard that? It's post-traumatic stress syndrome, which will not be as harsh as post-traumatic stress disorder. And one of the reasons they're looking at adding PTSS is so it won't have the stigma and we won't have so much an issue with this. Okay, so I spoke to you about a few of my guys that, and you probably have some of your own stories as well, that have some physical issues that go along with the PTSD. Heart issues are number one. And skin disorders are high up there. And with hair loss and rashes and eczema, psoriasis. Both of my guys have a lot of GI issues. Muscle loss. And the one guy, the NSA agent, has had brain surgery twice. And the other two of the guys have had some lung issues and some pulmonary issues and have had some oxygen. Any of your guys had, and I keep saying guys, and I know that very well that there's a lot of females that we work with as well. Any of your folks have some of the health issues as well? Yeah. Okay. Here we go with the family issues. You've heard this. If you were to have a family, you would have been issued one. That's one of the sayings from the military. Now, you're going to tell me that in here, 55% report negative effects on family. Now, and then 50% report negative effect on family. The one is male and the other one's female. So the 55% males report negative effect on family, and 50% female report negative effect on family. I'm sorry that I left that out of there. And 55% of the people are married that are in the military. And have anybody heard, why don't zebras get ulcers? Have anybody ever heard that story? Zebras don't get ulcers because they don't worry. So we talk about zebras not getting ulcers because we tell our clients, it goes back to the TFCBT. It's something I learned in TFCBT. And I put that in there so I could remember to tell you. When we give them the triangle and tell them, when you start to think the negative thoughts, because we have all been taught a life lie. Some of us learned something that's wrong. So that negative thing we tell ourselves over and over, we want to break that and say, just stop it and start to tell ourselves something positive. Okay. We say zebras don't get ulcers. So those of us doing TFCBT will remember to turn a lie into a positive. Zebras don't get ulcers because they don't worry. So if we don't lie to ourselves, we're not going to worry. We're not going to get ulcers. So today you might not have remembered, don't lie to yourself, think positive, but you'll come away thinking, I learned a weird thing. Zebras don't get ulcers. That's why they taught it to us. So I passed that on to you. A weird thing, but when you learn something weird, you remember something weird over something straightforward. So that's why that's in there. Tell your clients, just stop it and turn the negative into positive. Anybody in here know who Bob Newhart is? Okay, there's a YouTube video called Just Stop It. Have you seen it? I will have some of my clients who might appreciate Bob Newhart to watch it. And then I'll tell them, now put your band on and just say, just stop it. So just stop it. For those of you who don't know who Bob Newhart is, go to your computer or your little smartphone and look up Bob Newhart. It's a 6.2 YouTube on Bob Newhart, who plays a psychiatrist. And he is making fun of us as a therapist. And there's a lady who's a comedian making fun of our clients. She has a weird fear. And he's making fun of us saying, hey, you therapists, you want to charge a bunch of money and I can cure her in less than 5 minutes. And he's telling her, you got this weird thing and I can make you just stop it and you can stop it. So anyhow, it's really funny. A lot funnier than what I can explain it, but watch it. If you and your clients that might appreciate it, they watch it and then they'll remember it, know where they're beyond. A lot of my older clients will watch it, they appreciate it, and they actually do the just stop it. Okay. So we have the chronic illness, physical sleep. So any of your clients have chronic illnesses and trouble sleeping? A lot of them. All right. We're doing pretty good on time. I've only got a couple slides left. So issues we talked earlier, our clients who are military, if they have suicide ideation, they're going to be more likely to complete it. So we want to really be on top of it with them, don't we? And we have to be really close with them on the psychosocial adjustment. And we want to be mindful of any of their illnesses. And one of the guys who was doing ethics earlier today said, you know, we're not medical doctors and we're not nurses. And we're not. And we're not going to tell them what medicines to take. But if we have a client that's sick, as their therapist, we should have a signed release with their medical doctor, and we should challenge them. Have you gone to the doctor? Are you taking your medicine? We have a right to ask them if we see them being sick, if have they gone to the doctors? Are they doing what they need to do, right? Okay. Also, you know, there are pieces of PTSD that we can address, like anger, anxiety, depression. We can work with those pieces. We can work with anger management. We can work with anxiety. What do we do with their loss of self-esteem? Do you get really concerned when they have some apathy? Do your guys get apathy? And then we have a lot with the fibromyalgia. Okay. We've got folks that medicate with substances. What do you know? What do most of your folks self-medicate with when they're in the military? Alcohol. Why alcohol? Because it's legal. And you can't test it. They're not going to go anywhere when they're drunk, right? It's legal. You can't test it, and they're not going to go anywhere when they're drunk. That's a big difference between them and the civilians. All right. But they do. They drive on Jackson. And that's part of the aggressive driving that happens down here. Lots of them with DUIs. Yes. Yes. So what happens, those of you who work with the alcohol population, what happens, people think that they're okay to drive, don't they? Because their tolerance level has increased now. So they enjoy life when they're drinking. It helps them forget about stuff. They can get an adrenaline high. Some of them drink as a punishment. They're mad at themselves, right? They're angry with themselves. And then the substance becomes an independent addiction. It's separate from their mental health issue, right? Now, there are a few of the people who might use something else. Marijuana seems to be the other drug of choice, and North Carolina seems to be moving towards making that legal. And one of my trainings is on marijuana, not marijuana, not your pappies of the 60s, because it is much, much more potent today. That people are growing it. It's not in those little blocks that they're brought in from Mexico and Colombia, and more of the flower is being used, and it's much, much more potent. So people are getting much more high from it. So we may have a little bit more to deal with, those of us who work with the military and the first responders. When they self-medicate, you know, what happens? Not thinking clearly. Now they might start to think about harming themselves or someone else, right? Has that happened? Okay. And They start working all the time to occupy their minds. They don't want to think. And they're going to pull away from the people they really care about, thus, again, needing to work with the family. All right, here's our measures for testing. Life events checklist. And the primary care can do the PTSD screen. There's a combat exposure scale. Any of you use that? Familiar with it? And we've got the Beck Depression Index and the alcohol substance index and the SASE and the SUDS. And the psychological costs of war are sleep. Many of them only get 2 hours. The head is constantly running and thinking. They recall the memories. Trauma is they lose a buddy or they have self-injury and they don't know who they can trust. And my the man who supervised me for my PhD is in faith-based. He ran over a landmine in Vietnam and is blind. He had a dream that he would do that and told them about it. And they told him he was crazy. But he is a minister, he's married, he has grandkids today. He went through some severe PTSD, but he's all healed from it today. But he went through the artillery fire, all the mortar, the blasts, and the bombs and all this. A lot of my guys have gone through this as well, and you probably have had some stories from your guys. Okay, so 56, here's some stats from the military government. 56% of the vets were exposed to combat. 10% that were exposed to combat are heavy drinkers today. 34% use prescription drugs. And of those exposed to combat, 23% have depression, 43% have anxiety, 10% have suicide thoughts, and 18% have extreme anxiety. And at least 30 to 60% of those returning from active combat will be diagnosed with active PTSD. And co-occurring disorders related to PTSD and PTSS, they have suicide attempts, and there are some completions. There's depression, anxiety, and substances. The roadblocks to help are many vets are unaware they have PTSD. Did you know that? That's why some of our statistics are so low. And there's problems not apparent to those around them. And people don't know why the vets are unaware. And it's the stigma. More barriers are some of them can't access help. They're afraid they'll have a stigma. There's fear of what happens if I do get better? Is it possible to get better? If I start crying, I could cry and never stop. So steps for resiliency are positive role models, positive emotions, having a purpose in life, social support, and having a team. And steps for helping is listening, respect, support, and being serious. Asking if they want to talk. Being alert, looking for risk issues. Don't tell them you understand. You know what? We can understand they have an issue, but we never will understand what people are going through. Remember, PTSD is an explanation, not an excuse. Vets may get angry when triggers arise. We have to help them understand that they have a higher violence rate with their spouses. And violence and PTSD link is still weak. Okay, I got 5 minutes, guys, so I'm going fast. Alcohol and depression are risk factors for aggression. Anger and aggression are connected to hyperarousal, and TBI could be a risk factor. And when we manage stress and anger, don't confront, learn the cause, prepare, be grounded, and look for alternatives to medication. Enhance their safety, help them prepare for the future with coping skills. And family, teach active ignoring, praise, teach and praise, rewards, relaxation, and confidence in setting limits. And don't reinforce the avoiding and coaching. And normalize multiple conflicting feelings and education. And guys, we spent too much time talking. I wanted all your information, but that's it. And there's our resources. Thank you. Yes.
Hi, I just like to say when we was talking about the marijuana, there's it's a special on PBS and you can pull it up online also. It's called The Marijuana Question. But I do think it's gonna become legalized in North Carolina.
Well, thank you. Thank you all. I hope you learned something today and thank you for coming. And don't forget the free CEUs and email me your emails. Thank you.